Welcome to the December edition of the Urology Journal Club podcast. We're going to kick off with a research highlights from the British Journal and two papers to consider here very briefly. We know that there are a variety of histological variants of bladder cancer. These subtypes, such as micropapillary and plasmacytoid, have a reputation of having a more aggressive phenotype, and it would appear that these authors have been able to find the cause of that. And although there are various different histological subtypes, they all appear to exhibit a similar gene which encodes for a surface protein. And so that may, in fact, access a diagnostic technique in years to come to diagnose these subtypes of aggressive cancer. I think the second paper considered here is important. This relates to research which has been published many times by a Swedish group looking at the long-term survival of men enrolled, roughly 700 patients between the late 90s and early 2000s. And these patients were randomized to either radical prostatectomy or what might best be termed watchful waiting nowadays, at which time they would receive androgen deprivation therapy. And they were able to show a significant difference between those who died of prostate cancer was 25% following radical prostatectomy versus 42% in those who had simply received watchful waiting, and that was a 30-year timeline. And they said that the number needed to treat to prevent one prostate cancer death had fallen from 58 to 6. So on the face of this would appear data very much supporting radical prostatectomy to reduce deaths. But I think it's important to consider that 90% of these patients were clinically detected. So this is clearly a different era to the one that we're in now with PSA screening. And therefore they concluded that based on their findings, only men diagnosed with prostate cancer by PSA testing in their 50s and possibly early 60s are likely to gain significant benefit from radical prostatectomy. And I think the message here is quite clear, related to the natural history of this disease, and whether men who are older or PSA screen detected are going to benefit from surgery needs to be questioned based on these findings. Moving now to stones. This paper comes from the World Journal of Urology and is titled Stone Extraction During Flexible Ureteronoscopy with or without a Hydrogel Method. And this is a commercial product named Medinic, and the way it works is very much similar to the old blood clot technique used in the so-called coagulum pyelolithotomy, where a blood clot would grasp up all the small fragments, and they've evolved that method here. And we know that we often refer, perhaps erroneously, to clinically insignificant fragments, these small fragments which are difficult to wash out or to basket out, and nowadays even dusts. And so this new method involved injecting a biocompatible hydrogel into the calyx to encapsulate these fragments. And not surprisingly, they were able to demonstrate that the hydrogel method significantly retrieved fragments smaller than 1 millimeter. However, the duration of surgery was a bit longer in order to deploy the hydrogel, and it appeared safe and feasible, and may well be something that we can combine with other methods such as negative pressure suction like the Cleopatra to get rid of these last dusts and fragments. The next paper comes from Urology, and two of the lead authors here, Ranjib Matthews and Anthony Schaefer, colleagues that I was fortunate enough to work with in Uganda about a year ago on one of their outreach from the United States to Kampala to manage patients with bladder exstrophy. These two colleagues are from the Hopkins group, which is some of the pioneers of the modern staged repair. And the topic of this paper relates to whether delayed primary bladder exstrophy closure is the new norm, and they had a big database of roughly 77 patients. Now, historically, primary closure for bladder exstrophy has been performed within the first 72 hours. One uses the pinch test to assess whether there's adequate plasticity of the pelvis, and if there is, you can avoid osteotomies. That's what I've been taught and what I practice, and yet it is a relative emergency to get that operation done before the first 72 hours. Early closure is believed to promote early bladder cycling and optimal bladder growth, and to promote continence, and it has the advantage of, as mentioned, of approximating the pelvic bones without osteotomies. However, delayed primary bladder exstrophy closure requires, for practical reasons, and this work has really come from teams like in Brazil, where they have a traveling group who would go from region to region to close bladder exstrophies. Obviously, this isn't possible to do as early, and there's the obvious concern that certainly in the first 72 hours there's quite a high rate of perioperative complications. So there has been a shift towards delayed repair, and this certainly, the authors wanted to know whether this had delayed repair was more popular in the United States in pediatric hospitals. And they were able to show in their cohort of 77 males, of these 70% had an epispadias closure and 35% had pelvic osteotomies coded within the first 2 days for bladder exstrophy, while the majority, 85%, of osteotomies occurred in patients whose bladder closure had been performed more than 7 days. In 4 of the 5 years of the study, the median age of bladder closure within the first week was declining. So they were able to conclude that only a third of patients underwent pelvic osteotomy synchronous with bladder neck closure. So I think the message here is that delayed closure is in fact the new norm, and I think this is a sensible thing. It allows potentially for these patients to be managed in more high volume centers and with interest groups such as in Brazil, and I think that this paper is worth reading, anyone who is involved in this kind of work. Our final paper considers the management of a psychoureteric reflux in children. We know that VR is associated with febrile urinary tract infections, potentially renal scarring, and in some patients reflux nephropathy. Yet only 10% of children with reflux nephropathy in fact do develop hypertension or progress to end-stage renal disease. Surgical management nowadays is endoscopic correction, the sting or a HIT technique for lower grades, while ureteric reimplantation is reserved for high-grade reflux. This paper considers a very specific situation where you've got high-grade reflux on one side and low-grade on the other, which in fact in my experience is a relatively common scenario for it to be bilateral like that. And they were asking the question, what's the best method to manage that? And they had a total of 140 patients who were included. They had 40 in group 1, which was essentially those who underwent bilateral endoscopic correction, so that was group 1. Group 2 underwent bilateral intravesical reimplantation, or group 3, where they had a combined approach, in other words, reimplant the bad side and sting the good side. So what were their findings? Well, they were able to show a success rate of only 40% in the endoscope only group, whereas the reimplantation or reimplantation plus endoscope had up to 94 and 95% respectively. So clearly endoscopic management of the high grades are not going to cure, and perhaps a combined approach where you sting the one side and reimplant the other has a very good outcome, and maybe that's the best option for this unique group of children. Thank you very much for your attention, and look forward to seeing you in the new year 2026.